Good morning, everybody, and very welcome to everyone around the world to this OCAD lecture. My name is Robert Lambert, and I'm a radiologist at the University of Alberta in Canada, and it's my very great privilege and pleasure to present my colleague who's going to speak to us today, Dr. Walter Maksymowych. I've known Walter for 30 years and have researched very closely with him, spent many years working with him, over 20 years. Walter is a rheumatologist in the Department of Medicine. He has an incredible experience in a whole range of rheumatology, including basic science, and has a large laboratory that he works. But in the last 20 years, he's become more and more involved in diagnostic imaging and prognostic imaging. He's published over 300 manuscripts and is a leading light in many organizations that have their fingers deep in the world of imaging and rheumatology, such as the ASAS organization, GRAPPA, and Spartan. So without further ado, Walter is going to talk to us about the interaction between and collaboration between radiologists and rheumatologists and how important that is for the clinical setting. Thank you, Walter.
Thank you very much, Rob. And hello, everyone. I was about to say good morning, but I realized that there are people from so many different time zones, but it is an early morning for me. Sun isn't up yet, but I hope to shine some light into the collaboration between rheumatologists and radiologists, which I think is of crucial importance to the management of patients with spondyloarthritis. So I'm just going to share my screen with you, if I may. So it just says the host is disabled.
I just re-enabled it. I apologize for that.
Okay, we'll just try again. There we go. And so hopefully everyone can see my screen very nicely there. And yes. I have all the appropriate logos, hopefully. So when I talked to Rob about the kinds of topics and the approach to the presentation, Rob had suggested that I focus on the following key questions. So which are the really important clinical scenarios that demand imaging? And some types of imaging are not readily available or expensive. And sometimes we have to focus our imaging resources. Secondly, when should the radiologist be sensitive in their reporting? And when should they be specific? And when do radiology reports cause problems in the management of patients? But I think before I tackle those questions, what I would do is focus on what I think are some key principles of collaboration between rheumatologists and radiologists. And I have to say, this is very much based on the many fruitful years of collaboration that I've had with the Department of Radiology at the University of Alberta, and of course, particularly with Rob Lambert. And I think this is also based on our experience interacting with rheumatologists and radiologists internationally. So the first point that I would make is that spondyloarthritis is indeed a serious disease. I think occasionally it's been thought of as perhaps not too serious a disorder, but it is a serious disease, as I'll highlight shortly, and highly effective therapy is now available. And that's why we think that patients should be prioritized for advanced imaging. These are not patients who should be lumped together with other patients with non-specific back pain. These patients should be higher up the list of prioritization for advanced imaging. So the first point I will make is that there is a higher mortality in patients with spondylitis. This is related to the degree of active inflammation. Here in this cohort study, C-reactive protein and increasing levels of C-reactive protein are associated with a higher odds for mortality. Lack of use of anti-inflammatory therapies, and you'll notice diagnostic delay are associated with an increased risk of mortality. And then there is a cost of illness, almost 10,000 euros per patient per year, both direct and indirect healthcare costs. And this, in fact, can be substantially magnified by some of the extra-articular features that occur in this disease: iritis, colitis, psoriasis. We have a substantial delay that we have to contend with, and I'll highlight to you the importance of that delay, the problems that it may cause with patient management. I've already highlighted the impact that it might have on mortality, but here you see two graphs, and the first graph is age at first symptoms, second graph age at first diagnosis. And you see that the gap between the curves illustrates the diagnostic delay. And the diagnostic delay we can see is somewhat greater in females. And identifying this disease in females is that much more challenging. I don't have the time to go into the reasons for this, but I will make one comment that is very germane to imaging. So this slide illustrates the differences in ankylosis. We have 4 grades, and these grades reflect changes in the sacroiliac joint and the spine and the degree of new bone formation in the spine. And you can see that the higher grades occur much more frequently in males. So perhaps with all of the plain radiography that's used to evaluate patients, it's not surprising that male patients are detected a lot sooner. So we do have an array of, frankly, quite phenomenal therapies. So the biologics, the TNF blocking agents, have transformed the management of this condition. There are a variety of these TNF blocking agents available. I'm not going to discuss them. They all have very similar response rates. Here I'm showing something called the ASAS 40 response. The way to think about that is that this is a major clinical response. Someone who has an ASAS 40 response is going to be feeling very well after receiving treatment. And we typically see an ASAS 40 response often as soon as 2 to 4 weeks after the start of treatment. And by about 12 to 16 weeks, we're seeing a plateauing of the response. So this is a rapid response. You don't have to sit around waiting to see the response. And then more recently, we have a new category of biologic. The prior category I showed you targets TNF. The newer category targets interleukin 17. And again, you'll see an ASAS 40 response. I showed you earlier it was around 40% with the TNF blockers. It's similarly around 40% major clinical improvement. And this is an established ankylosing spondylitis. And by established, I mean a disease duration of already about 10 to 15 years. So, and even in patients with severe ankylosis, we see good response rates. So it's about 40%. Now, here's the key point and a key slide for rheumatologists and actually also for radiologists. And this tells us what the response looks like if we identify these patients early, You can see here the symptom duration is less than 5 years. And if we start these patients on a biologic very early in disease, so the green bar here is the ASAS 40. And you can see with early treatment, the response rate is almost double. So early diagnosis means early intervention, which leads to better treatment outcomes. So this very much places the onus on a crucial role for that collaboration between the rheumatologists and the radiologists. This is why we need the prioritization. This is why we need the good collaboration between us. Here's another reason why we're starting to see evidence that these agents might ameliorate radiographic progression. They are not simply symptom modifying. They don't just make patients feel better. They may actually prevent radiographic progression. And we just had a paper accepted in arthritis rheumatology from our own cohort at the University of Alberta, demonstrating this, that TNF therapy does prevent radiographic progression. And in this red box here, again is highlighted that the impact of TNF inhibitor therapy is best observed in patients with short symptom duration of up to 10 years. Another reason why we want to identify these patients early. What's the second important principle? So what has happened over the years is that imaging has played and continues to play a very important role in governing access to treatment. So in many parts of the world, a rheumatologist cannot prescribe one of these advanced therapies unless the patient meets modified New York criteria. And for other situations, again, imaging is important. And I'll come to this very shortly. And so the implication of this is that radiologists and rheumatologists really need to be on the same page with their understanding of the role of imaging and classification criteria. Because when I'm filling out that paperwork to my local health authority to get access to a biologic, I'm going to have to put down what the radiologist told me. And so the reporting is going to be crucial. It's got to be accurate, and it's got to be in the patient's best interests. So here's radiographic sequelitis, and here is the grading that is used. What you'll see immediately as you review the wording of the grading is that its interpretation can be fairly subjective, and different readers can place different emphasis on different aspects of the pathology that we see in the sacroiliac joint. And so radiographic sequelitis from the rheumatologist perspective is somewhat of an imprecise tool. And to complicate matters somewhat further, we now have 2 indications for treatment with these advanced therapies. So the 2 indications are non-radiographic disease and radiographic disease. And they're based on this paradigm illustrated in this slide, that before patients develop typical radiographic features such as sacroiliitis on radiography, they go through a non-radiographic phase. And these patients may still have very comparable symptoms. And in fact, if you use a variety of outcome assessments, these patients are equally impacted in terms of their quality of life. But you may only see findings on MRI evaluation. And around the world, and for example, the FDA focuses a great deal on radiographic sequelitis in its evaluation of clinical trials and in the indications that are provided for the treatment of spondyloarthritis. Now, a problem with radiography is, first of all, its lack of sensitivity. And that's perhaps highlighted in these two cohorts. And you can see these are patients presenting with suspicion of ankylosing spondylitis or spondyloarthritis. They have features of inflammatory back pain. You can see relatively few of them, 10 to 15%, have definite radiographic sacroiliitis. You can see clinical criteria, classification criteria, around half are considered to have axial spondyloarthritis. And we can see here that bone marrow edema on MRI is observed in at least twice as many, going up to 3 times as many patients with suspicion of spondyloarthritis. So lack of sensitivity is the first problem. The second problem is lack of reliability. It's actually challenging to get 2 central readers. And actually this data is from expert musculoskeletal radiologists from Paris at a leading center who were asked to judge whether the radiographs in front of them met the New York criteria for radiographic sacroiliitis. And you can see here by this 2x2 table, you get only a modest kappa for reliability. And in fact, it doesn't matter how much you try to train people, or calibrate, I should say, people, how much they discuss in advance, you really can't improve this reliability figure. Intrinsically, radiography is not really the optimal way, of course, to evaluate the sacroiliac joints. And everybody, I'm sure, on the call appreciates that already. However, it's therefore surprising how much credence the regulatory authorities and access to treatment depends on assessment of radiographic sacroiliitis. Now, because of this issue, and because rheumatologists, of course, want to treat patients before they develop radiographic sacroiliitis, we don't want to wait 7, 8, 10 years before people have developed radiographic sacroiliitis. In the meantime, people suffer, have an impaired quality of life, impaired work, and so on. So this is the rationale for the development of the ASAS classification criteria. And they have 2 arms. There's an imaging arm on the left here and a clinical arm. And you can see the imaging arm requires either the radiographic feature we just talked about, or the presence of active inflammation of MRI, highly suggestive of sacroiliitis. So let's just explore that in a little bit more detail. So here's the definition. What constitutes a positive MRI for classification of spondyloarthritis? And the definition here was based on consensus, international consensus of radiologists and rheumatologists in the ASAS group. And the proposal was that 2 BME lesions on a single slice, as we see here on the left, or 1 lesion on 2 consecutive semi-coronal slices would be considered as meeting this definition. You'll notice there's a qualitative aspect of this definition. The appearance of the bone marrow edema has to be highly suggestive. And you might say, well, what's highly suggestive? But this is important, and identifying MRI inflammation is important because treatment responses are also much more evident, especially in non-radiographic axial spondyloarthritis. They're evident in patients with inflammation on MRI or elevated CRP. And here's the difference between the active therapy and the placebo group in patients with short symptom duration receiving a biological therapy. And you see in patients with normal MRI and normal CRP, there's no treatment group difference in this placebo-controlled RCT. And you see this in the non-radiographic patients, irrespective of the biologic that's been tested in RCTs. And so this has led to the following authorization, and it's not just the European Medicines Evaluation Agency, but across the world, that for patients with non-radiographic disease, so in early disease, you really must have objective evidence of inflammation as evident on either CRP or MRI before they will grant authorization for the use of a biologic. So this is filtered down to all the health authorities who grant access to biologics. So here's another reason why we need to understand these classification criteria and how we need to be reporting back the findings on imaging to the rheumatologist. Now, problem is that as this positive MRI has been defined in the ASAS definition, as time has gone on, we have realized that this definition is not adequate and that there are false positives with this definition. Here's a broad section of different types of individuals, from patients with SPA, and you see 91.5% have bone marrow edema meeting this definition. But so do 20 to 25% of healthy participants. So do some chronic back pain patients, athletes, and most particularly women shortly after the postpartum period. If the bone marrow edema extends at least 1 centimeter from subchondral bone, that appears to be something that's very helpful and has specificity, high specificity for axial spondyloarthritis. So what might false positive bone marrow edema look like? So here we've got a 42-year-old male with what sounds like inflammatory back pain, but is B27 negative. That's very symptomatic. Now, this is the kind of patient where the imaging is going to be very important. The patient has failed traditional conservative therapy. High symptoms, the BASDI is an outcome measure that evaluates symptom severity. You need a BASDI of 4 before you can get access to a biologic in pretty much everywhere around the world. The pelvic radiograph is normal. So now the interpretation of the MRI is crucially important. And the MRI report comes back indicating that there is increased signal on the STIR scan, 2 consecutive slices. So an uncritical evaluation of the classification criteria and the application of the bone marrow edema definition would say, well, it's a positive MRI. Let's get this patient started on a biologic. But this is, in fact, a typical appearance of false positive bone marrow edema in the inferior portion of the iliac bone. Here's another example, 39-year-old male, inflammatory back pain for 6 years, this time B27 positive, and again, failing conservative therapy, unremarkable pelvic radiograph, very symptomatic. Should this patient go on a biologic? This is a high priority indication. And here's an example where the radiologist really, in my view, needs to be specific rather than sensitive. This patient we really need to understand if this patient has SPA, and whether that abnormality points to sacroiliitis. And again, this is something that you might see as a false positive bone marrow edema signal in patients with early osteoarthritis. So these are two locations where people have typically found false positive bone marrow edema, where the diagnosis has been evaluated according to the totality of the clinical lab and imaging information. And so those areas that I've just indicated are red flag zones for the interpretation of bone marrow edema. And we have to be careful with this interpretation. And one further point is that structural lesions can be very helpful in ascertaining if the bone marrow edema is indeed false positive or related to axial spondyloarthritis. There are other ways and other considerations for that will facilitate interpretation of bone marrow edema. So increasingly, we're using low radiation CT. Something that is a key principle that has been instilled in the ASAS membership is the importance of contextual interpretation with structural lesions on T1 weighted sequences. And there's growing interest in the use of erosion sequences that will tell us whether these patients may be developing early structural lesions. So this is encapsulated in this statement and a key principle of interpretation of MRI scans, that when we're making a decision whether a bone marrow edema lesion is highly suggestive of spondyloarthritis, the concomitant presence of a structural lesion may be very helpful in the decision whether this is spondyloarthritis or not. And here's a good example of this. So we have again a patient who is 42 years old, and we often see these challenges in patients in their late 30s, early 40s. Suggestive history of inflammatory back pain. Here the patient even has psoriasis, which is helpful. Slightly elevated CRP, pelvic radiograph non-specific features, failed conservative therapies, very symptomatic. This happened to be a colleague of mine who's a dermatologist. And you can see the bone marrow edema signal in the left lower iliac bone. But in addition, the left lower iliac cortex is very clearly abnormal. So we see loss of the dark cortical bone, the inferior portion of the iliac bone, and loss of the marrow fat signal. And there's also some irregularity of the cortex on the right-hand side. So we can be very confident in this case that the patient has axial spondyloarthritis. There has been a very recent publication which might provide some further insights and help to the interpretation of what constitutes a definite positive MRI for active lesions. I don't have the details of the analysis that led us to this conclusion, but we have a modified definition for what constitutes bone marrow edema highly suggestive of spondyloarthritis. And this is bone marrow edema in 3 consecutive slices, or bone marrow edema that might be present in more than one location, but in a total of at least 4 sacroiliac joint quadrants. And this is a manuscript that is just in press. And then the third principle of collaboration is one that I think has somewhat been neglected as we've moved into our respective silos because of the advent of electronic medical records and remote reporting. And rheumatologists are often seeing patients and evaluating the electronic medical record and the imaging downloaded from the PACS. And radiologists are reporting from another building and perhaps even another part of the world. And rheumatologists often state in surveys that they would like to see more direct interaction with radiologists. And I think it's very helpful to radiologists to have adequate clinical information. And this will optimize interpretation of the imaging. It's also important, I think, for rheumatologists to clearly think and convey to the radiologist the indication for the procedure and the implications for management, because this is going to make the radiologist think about, well, do I interpret this imaging with respect to emphasizing sensitivity, or do I interpret the imaging with respect to specificity? Where do I sort of calibrate and set my detection threshold for lesions and what I state in the report? So what constitutes adequate clinical information? There's certainly age and gender. If you can imagine, until relatively recently, for recruitment of patients into clinical trials and the evaluation of radiographic sacroiliitis, the radiologists have been blinded to age and gender. I frankly think that's absurd. Symptom duration is clearly important. B27 is going to be very important. How we interpret a B27 negative and a positive patient is going to be very different. Symptom severity, because that will determine whether I'm considering a biologic. The radiologist needs to know if I, as a rheumatologist, am contemplating a major change of treatment to something that's going to cost $20,000 a year. And then some other considerations, sometimes disability. So what I'm going to do now is go through some clinical scenarios that I think highlight this approach. And I'm going to switch into DICOM. We've discussed the key principles, and I think now we can start addressing those questions that Rob thought would be helpful to indicate some of the key applications of those collaboration principles. So for this case, we're going to ask, does this clinical scenario demand imaging? And should the radiologist be sensitive or specific in their reporting? So here we have a 42-year-old male who is a construction worker. And the rheumatologist thinks that this patient has some features supportive of a history of inflammatory back pain. The patient is stiff in the morning, and the pain tends, however, there are some features that don't fit. So the pain tends to be worse with activity, and the patient does not have nocturnal back pain. So this is sort of not a slam dunk history of inflammatory back pain. Now, the patient has been trying to take some anti-inflammatories, but smokes and cannot tolerate treatment. So now your conservative therapy is limited. Now, the patient has had 2 attacks of acute anterior uveitis, which greatly increase the pretest probability of axial spondyloarthritis. On the other hand, the B27 and the CRP are negative. You can't rely too much on CRP because the sensitivity in axial spondyloarthritis is only about 40 to 50%. B27 occurs in about 85 to 90%. So this is very helpful. Now, the issue here is the patient is now getting symptomatically worse. He's finding it hard to work and is seriously contemplating disability. So there's three issues here that I think justify really quite progressive imaging. So the first one is lack of a clear diagnosis. Secondly, the patient is very symptomatic and may be thinking about disability, so a major change to their life. And the third issue is that I, as a rheumatologist, may be thinking about starting this patient on a biologic. So all of those issues around interpretation of radiographs and then going on to appropriate, relevant interpretation of the MRI scanning are very important. So let's switch to the DICOM imaging. And I've got a window open here, which I hope you can all see. But please let me know if you can't see the window.
We can see it.
Great. So here's the first case. And ignore these questions here. We do, myself and Rob do a lot of workshops, and our workshops are very interactive, and we try and elicit audience responses. It's often quite interesting how people interpret radiographic sacroiliitis. So let's just window the sacroiliac joint. So hopefully you will agree that this patient does not have features of radiographic sacroiliitis. So now, having seen this, and in view of those questions, I'm not going to stop at a radiograph. I clearly need more information, and the decisions relevant to patient management are very important, and I need decisive imaging. So here we have the T1 on the left, the stir sequence on the right. I'm just going to magnify this. And just window a little bit. And let's just scroll from front to back to evaluate the imaging further. And so as we scroll from front to back, we can see that there is some irregularity of the right iliac cortex, the left iliac cortex. We don't have a lot of findings on the stir sequence. We have some bone marrow edema around an erosion. And if I magnify the right sacroiliac joint, we can see that there's an area of bone marrow edema, which on its own perhaps is not convincing. But we do have this area of erosion. We see the area of erosion on at least 2 slices. And I think our confidence is going to be enhanced if we see the bone marrow edema and the erosion on at least 2 slices. And I think this is a nice example of contextual interpretation of imaging. So with this patient, we got again some bone marrow edema on the left-hand side. And I'm just going to show you the left iliac cortex magnified on the T1 weighted sequence. And so we also have some abnormalities on the left-hand side. The left iliac cortex is not normal. And so we have a combination of subtle bone marrow edema changes and certainly meeting the ASAS definition, but we also have structural lesions. And so I think in the reporting, what we would want to emphasize is that yes, there is some bone marrow edema, and yes, the patient has inflammatory features, and your confidence in the diagnosis is enhanced by the finding of erosive changes in at least 2 locations. And this is, I think, a very good example of contextual interpretation. We can come back to that case later. I will provide some time for discussion. But I think that kind of report would be very helpful to me. It would allow me, that kind of wording would allow me to submit the report to the local health authority that provides access to therapeutics, and would also give me the confidence that this patient really does have a diagnosis of axial spondyloarthritis. So we're using the imaging here to confirm the diagnosis. It's a challenging diagnosis, but we can be quite certain this is the problem. And secondly, to ensure that the patient has access to appropriate treatment. So that is the first case. So we'll go back to, so contextual interpretation is crucial because this might increase specificity for a diagnosis. Now let's approach another case. This is a 36-year-old female. And I have to say, as a clinician, it's more challenging to make a diagnosis in a female, especially postpartum females, than it is in males. So again, we have a relatively short duration of a history. Morning stiffness of about 30 to 60 minutes. Now here, we've got some additional features, nocturnal back pain, which has some specificity for spondyloarthritis. So now we have quite a suggestive history of inflammatory back pain. Very symptomatic patient with a high BASDI. Again, another patient who cannot tolerate anti-inflammatory drugs. Patients really don't like to take these medications because they often upset their stomachs, and they've heard nasty things about these drugs causing heart attacks. Now, what's complicating the interpretation in this patient is that she has diffuse arthralgia in peripheral locations, lots of entheses that are tender, and it's not clear to the rheumatologist if this patient might actually have fibromyalgia. And fibromyalgia is certainly within the differential diagnosis of women presenting with inflammatory type back pain. Now, the patient's B27 positive has a slightly elevated C-reactive protein. So we have several indications that I think demand imaging. Again, the physician isn't certain that this patient really has axSpA or fibromyalgia. And actually, after the patient had an MRI done, the report led to the physician changing the diagnosis from maybe to a definite yes. Now, that has big implications in this case because the patient's failed anti-inflammatories, has very high symptoms, is now eligible for a biologic. So this patient may now be starting on a $20,000 a year drug, potentially for decades, because of the MRI interpretation. So what was it that the radiologist saw that led to this decision? So let's go back to our imaging and let's have a look at this case. Okay, so this is case 8605. So first of all, we have the radiograph. And let's just optimize the image. And let's just window. So I hope you'll agree with me that the radiograph is unremarkable. And then let's have a look now at the MRI scan. So we'll just window. And let's just scroll through and see what we can find. Okay, so we've got two regions of bone marrow edema. Just magnify the images. We've got two regions of bone marrow edema in the sacrum on both sides. The focal areas of bone marrow edema, and there's some dark signal, and the bone marrow edema surrounds a region of dark signal in both the T1 and the stir sequence. And our interpretation would actually be that this patient has an area of non-specific bone marrow edema around two small foci of sclerosis. Now, it's possible that the radiologist interpreting the image may have been thinking about the two slices of bone marrow edema in the ASAS definition and reported this as bone marrow edema suggestive, potential sacroiliitis. The wording here becomes crucial. What was precisely in the radiologist's report? The rheumatologist is keen to pull the trigger and start the patient in a biologic therapy because our instinct, of course, is to get the patient better, feeling better as soon as possible. But this is how I often end up seeing patients for a second opinion who have been on 3, 4, 5 biologics and failed them. And now I'm having to explain to the patient, well, actually, I don't think you have spondyloarthritis. And I think that when you review the T1 weighted sequence in this patient, I think it's hard to say that there really is a lesion that is specific for spondyloarthritis. Perhaps what would be a better approach if you weren't sure about the interpretation of the imaging, whether in fact there might be an erosion in the sacrum, would be to do low radiation CT. That could be helpful. And if you saw pristine cortical surface, then that would enhance your confidence. But I think this is a circumstance where specificity is really important. You're going to be making some very, very important management decisions for this patient that are going to impact this patient potentially over decades. I'll perhaps stop at this point and see if there are any questions. If there aren't, I'll show one or two more cases. But I see we've got just 10 minutes left before the end of the hour. So Rob, I'll hand it over to you to see what the chat box looks like and if there's any cases. I'll perhaps just stop the sharing at this point.
Walter, thank you very much indeed for that interesting and insightful discussion. We can receive questions either by an individual sharing their video and raising their hand, or by submitting a question through the chat box. I'm going to hand over to Berang, who's going to control the flow of the questions. And of course, it may be that some of the questions are best answered with one of your cases, Walter.
Okay.
So
Yeah.
we have one question. The last case, had there been an actual erosion, would you go heavier on the diagnosis?
Yes, very much so. So erosion has lower sensitivity, but much higher specificity than bone marrow edema. And so if you have erosion on 2 consecutive slices, or for example, in 3 sacroiliac joint quadrants, that will have specificity of around 95%. So of all the lesions that we see, if you have a definite erosion, and the very first case that I showed you, it's a subtle erosion. It's not one that jumps out at you, but it's there and it's definitely present in 2 slices. And there is bone marrow edema signal around the erosion, and actually there was bright signal inside the erosion cavity. And that's an example of a lesion that I think is highly specific for spondyloarthritis.
If I can make a point there also in relation to that question and your answer, Walter, I think that a lot of centers around the world in the last few years are starting to adapt their protocol and to introduce erosion specific sequences, recognizing that the interpretation of the inflammation on the stir, the fat on the T1, and erosion on an erosion specific sequence is incredibly valuable in this setting.
One question, what does Rob mean by erosion specific sequence?
Well, one that whereby, so there's 2 aspects to that. So one is to de-emphasize the inflammatory signal that you see on the stir and de-emphasize the fat signal that you're seeing on the standard T1 weighted spin echo. So you're de-emphasizing those components of the bone marrow signal, and then you do a high resolution sequence. And there's a lot of different ways of doing this, but most people are using some form of 3-dimensional gradient echo acquisition with fat saturation. There's a move towards 0 TE sequences and a variety of other ways of doing this. But the key thing is high resolution, and it creates the 3D gradient echo imaging creates a high contrast between the edge of the bone and whatever tissue is adjacent to that, if it's healthy cartilage, or whether it's granulation tissue in the erosion cavity or fluid in the joint space. It won't matter what's beside the bone. You'll have that high contrast between bone and the other tissue, and you see the border of the bone very sharply, and it makes it much easier to interpret erosion. And these slices should be in the range of 0.5 millimeter to 1.5. We're doing it, when we do it, we're doing it about 1.5 millimeters because it can take quite a bit longer to do it extremely thin. But high resolution 3D gradient echo with thin slice and high resolution.
Great, great. And we have a question from Dr. Pezesh from UT Southwestern. So if you want to unmute yourself and go ahead and ask, and then we have another one in the chat box to follow.
Good morning, this is Parham Pezesh from UT Southwestern. Thanks for the great talk. So we have a large population of SPA patients here, and we've also worked with Dr. Joel Tarek that I'm sure you know.
Yeah.
I have a question for both you and Dr. Lambert. We see a lot of these cases. We also do the protocol with the 3D imaging with 1 millimeter isotropic that is very helpful to show the erosions. My question is that there are cases that you see the changes not in the typical synovial portion of the SI joints, which would be like a anterior inferior. So you see that area is totally clean. There is no erosion. There is no bone marrow change or anything. But when you go posterior to like a more cartilaginous portion, fibrocartilaginous portion, you see some minor changes. And my question is that, to your experience, or Dr. Lambert, given that these changes are not in the typical location for synovial portion of the SI joints, how confident you will be to comment on spondyloarthritis? Because given my, as you mentioned correctly, my reports for spondyloarthritis is basically I try to be yes or no. I really try to be like indeterminate. So in those cases, I was wondering, how do you comment, or how would you get your impression?
Okay, so the synovial portion of the joint is actually confined to a very limited part of the joint, the anteroinferior 1/3, and much of the pathology affects the cartilaginous portion of the joint, which is much larger than the synovial portion. And so when we see erosion, and when it's been studied by histopathology, the histopathology is not one of synovitis. It's actually osteochondritis, and there's granulation tissue in the subchondral bone marrow that erodes through the overlying bone and cartilage. And so I think that erosion in the cartilaginous portion of the joint is observed quite frequently, even in early disease. It's not just in the anteroinferior synovial portion of the joint. In fact, there's no synovium, of course, in the interior of the joint. And this very much reflects osteochondritis. And when people have formally studied the specificity and sensitivity of different MRI type lesions, erosion comes up very high in terms of specificity, as I've mentioned. If you see it in the cartilaginous portion of the joint, especially with inflammation in the erosion cavity, we just recently had a manuscript indicating that inflammation evident in an erosion cavity is 100% specific for AXPAR. So erosion with edema around it, or inflammation in the cavity present in 2 slices, incredibly helpful towards a diagnosis. Rob, any further comments?
Only to emphasize that synovial proliferation and capsulitis is occasionally seen, but is never the dominant feature. Even when you see it, the cartilaginous and osseous components of the disease supersede the presence of the capsulitis. It's helpful in a case where you're undecided, but it's never there in isolation. Whereas the disease that starts in the center of the joint involving cartilage bone is frequently there without any change in the perimeter of the joint.
Great.
Thank you.
We have 2 questions in the chat box. The first one is related to the slice thickness. So if the bone marrow edema needs to be seen on subsequent slices, is there a standard slice thickness that you follow?
Yes, we actually have a standard image acquisition protocol on the Care Arthritis website. And you can download that. It's a PDF. It's international consensus-based image acquisition protocol that we recommend is used for diagnostic evaluation. And there the slice thickness is 3 millimeters. So that would be, but I think for structural evaluation, and Rob can comment further on this, that increasingly there are sequences that use a smaller slice thickness. Rob?
So for any magnet that is less than 10 years old, we have 3 millimeters for the T1 and stir, with the position matching exactly. If it's an older magnet, you can use 4 millimeters. And then the high resolution sequences are done at either 1/2 or 1/3 of the T1 slice thickness. So that we do those at either 1.1 or 1.65 millimeters, allowing for, because the 3D acquisition doesn't have a slice gap, whereas the T1 does. So we're doing a high resolution images at either 1.1 millimeters thick or 1.65 millimeters, so that you've got 2 or 3 high res slices per T1 slice.
Okay. And then we have a related question. It may have already been answered, but I just want to make sure that it gets asked. Is a single high resolution T2 Dixon sequence sufficient?
In my opinion, not. There's a lot of information on that sequence, and certainly the water only sequence provides all the information with respect to the stir. But the fat-only component of the Dixon can be hard to interpret in the presence of a whole variety of other changes. And so I do not consider it adequate for or comparable to the T1 weighted sequence. But that may, yet no one has produced an article to prove it one way or the other. And also with regard to erosion detection, the sensitivity or specificity of erosion on the Dixon hasn't been proven. If I were to do only one sequence, it would be the T2 Dixon with all the in and out of phase fat only and water only sequences. But at this point in time, there's no scientific evidence to prove that it's adequate to replace the standard protocol.
Okay, and I'm not sure if the question meant T2 water only Dixon or T2 fat only Dixon. Would you go with the water only?
No, if I was going to do the Dixon, I would do all four components. So in phase, out of phase, water only, and fat only. Because once
Okay.
you've decided to acquire it, it's simply a matter of which images you choose to reconstruct after the acquisition. Can I clarify one thing about the Dixon? And that is you can substitute the water only Dixon for the stir. That's for sure. So you could do T1 plus the water only Dixon as a substitute for the stir. That's for sure.
That's it from the questions.
Thank you very much.
If you would like to learn a lot more about imaging in axial spondyloarthritis, we have placed a lot of resources on a website, Care Arthritis. We also have an app which you can download. It's only available for iPhones at the moment, but in a couple of months will be available for Android phones as well. And there will be a lot of interesting imaging with an opportunity for you to provide your opinion as well and to communicate and interact with us. And we very much look forward to that. So I'd just like to thank you for your attention and for your questions and for this opportunity to speak to my radiology colleagues. It's a wonderful experience for me. Thank you so much.